lung ultrasound. Before I start, may I know how many of you are already using ultrasound for assessment of lung? Quite a few, actually, isn't it? I've been doing the same talk for quite a few years now, and one of the major differences I see is that more and more people are actually using lung ultrasound on a regular basis. And now that ultrasound machine is available in most of the hospital, ultrasound is establishing itself as one of the major tool for assessment of critically ill patients. And that's why it's very important to understand what is the principle behind use of lung ultrasound, and also what are the different pathognomonic features you will see, and we will be covering that in this talk. All we know about lung ultrasound is because of this great man. Any of you know him? Yeah, Daniel Lichtenstein is his name. He's a French intensive care specialist who started using lung ultrasound about 25 years ago, when even radiologists didn't know that lung ultrasound can be used for assessment of lung. He has done a lot of work. He has done a lot of research in this. He has written a lot of books on this, and he goes all over the world teaching how to do the lung ultrasound. Really a great person indeed, and he has been in India quite a few times. Now, it is very interesting about lung ultrasound, because as we know that ultrasound is a very poor when there is air, because air is a very poor conductor of ultrasound. That's why even the radiologist never thought that ultrasound can be used for assessment of lung. Now what happens is whenever there is a pathology in the lung, there will be some fluids, and it is the interaction of the ultrasound waves between this air and fluid creates a lot of artifacts, and lung ultrasound is mainly about the study of these different artifacts. Unfortunately for us, what happens is these artifacts are very specific in each disease, and by study of these artifacts you will be able to make a lot of diagnosis. Now which probes to use? I think most of the time it will be dependent on what is available. Actually any probe can be used, and there are three probes specifically which are used for assessment of lung. This is one of them. This is a vascular probe. This is a linear probe. It's a high frequency probe. It is mainly used for vascular ultrasound because it is very good, because it's a high frequency. It is very good for structures which are not very deep, and it gives a very good resolution. So assessment of the pleura, for example, this probe is very good. The next one, I'm sure you would have seen this probe as well. This is called curvilinear probe. Sorry, you're able to hear? Yes. Okay. So this is curvilinear probe. This is abdominal probe. So it's a 4 megahertz. So it's a relatively less frequency compared to a 12L or a linear probe. The advantage of this is it goes very deep, even though the resolution may not be as good as the linear probe. So this is useful for studying the deeper parts of the lung. And there is another one which Daniel Lichtenstein uses. It's called a microconvex probe. This is in between the high frequency and low frequency. This is usually 6 megahertz or 8 megahertz. The one I've shown, one we get here is 8 megahertz. The one Dr. Daniel Lichtenstein uses is a 6 megahertz. This gives you a good view for the pleura, and you can go deeper and see the deeper structures as well. So if you have, this will be useful as well. But as I said, most of the time will be dictated by whatever is available in the hospital, and you'll have to just make use of that. And any probe will give you good enough information about the patient's pathology. Now, what is the position you should have the patient for assessing the lung? Again, in ICU, we don't have a choice. Whichever position the patient is in, you'll have to do the assessment in that position itself. But ideally, if you can make this patient sit up and in the supine, will be a good position, because then the different parts of the lung you'll be able to access and do the assessment. How should you use the probe? This is the ideal way. There is a marker on the probe. The marker should be either directed towards the head or towards the right, and usually you will put it perpendicular to the chest. Which parts of the lung will you assess? Again, in ICU patients, you don't have much choice actually. It should be like your stethoscope. Wherever you would put your stethoscope to assess your lung, you should be doing the same thing with the lung ultrasound probe as well. Now, different papers have divided lung into different fields. Here they have divided into 6 fields. anterior 2, lateral 2, and posterior 2. And it is very important to make sure that the posterior part of the lung, you definitely assess how much of a difficulty it is, because most of the pathology will be in the posterior and the lower part of the lung. Now, when you hold the probe, what you will see is something like this. Okay, when you are holding the probe perpendicular to the chest with the indicator marker directed towards the head, the one on the left side, this black shadow, is the upper rib. One on the right side, the black shadow, is the lower rib. So that's how you will see. And this shadow is because of the shadow of the rib itself. That's why it is black. There is a space in between, that is the intercostal space. And there is a line just below the level of ribs, that is the pleural line. Okay, so this is also called bat wing sign, because it, I think, I don't know whether you will agree, it looks like a bat. Yeah, this is the wings of the bat, and this is the face of the bat. In actual ultrasound, when you put the probe, this is how you will see. This is one rib, this is another rib, this is the pleura. Okay, can you see the pleura there? It's a very white line. Now, one of the important signs you will see is what is called lung sliding. It's the shimmering or sliding of the lung, and it basically represents parietal and visceral pleura moving against each other. And it is a very important sign. Can you see here? This line, what I was talking about, pleural line, can you see that it is shining, it is shimmering? That means the parietal and visceral pleura are close together and they are moving against each other. It is a normal finding. There are a few other findings as well. Some of them are normal. They are shown here. One is A line and another one is B line. A line is basically, this is a schematic representation. This is the intercostal space. This is the pleura. These are A lines. Basically, they are a reflection of the pleural line, and they will be at equidistance to each other. Okay, and B lines are, they also start from the pleura, but they will be vertical lines like this. I'll show you the A lines first. Can you see these lines? These are A lines. They are just normal. They are a reverberation artifact. They are a reflection of the pleura. It just means that most likely the lung is normal. Okay, the next one is B line. B line, as we said, it starts from the pleura and it goes to the end of the screen, and it will be in the interpleural space. Why does the B lines come? As we said before, it is mainly because of the presence of fluid inside the lung. Okay, when there is no fluid in a normal lung, the ultrasound will just pass through, and the only thing you will see is A lines, which are the reflection of the pleura itself. Whenever there is fluid, the air fluid will cause the ultrasound to cause what is called a reverberation artifact. It will be just going inside and inside out all over the place, and that will lead to a sign called B line. Now, can you see any B lines here? There are quite a few B lines, isn't it? They are starting from the pleura, they are going towards the end of the thing. So they are called B lines. Now, there are some features of the B line. They start from the pleura, they reach the edge of the screen, they do not fade. You will see the whole line. They erase the A lines. When you have B line, you will not have A line, and they move with respiration. And as we said, it is caused by multiple reflection of the ultrasound beam in between the fluid and air, in between the alveoli and the interlobular septa. Important thing about B lines is it is also can be a normal finding. Up to 6 in a vascular probe and up to 3 in a curvilinear microconvex probe can be normal. If it is more than that, it is abnormal. And in 28% of the patients, according to the studies, in the lower part of the lung, you can have, and they are normal findings as well. The other important thing about B lines is, one thing is it will tell you that lung is not normal, there is fluid. What is the reason for fluid? You'll have to work out. It is very sensitive. Your chest X-ray might look normal, but your ultrasound will show that actually there is some pathology in the lung. There is some fluid in the lung. Another important thing is, as the disease progresses, you will see that the number of B lines increases as well. And another important thing is, as you treat the patient, as the patient's condition gets better, as the pathology gets better, as the lung fluid gets better, these B lines number will come down as well. So you actually can titrate the treatment based on lung ultrasound. I know, some of the faculty who had come for the last one, they were cardiologists. They were looking after patients with heart failure, and they had ultrasound in their OPD clinic, and they will titrate the diuretics based on the ultrasound examination. So it is very, very useful and much better than your chest X-ray. Here, just to show you how increase in pathology will cause increase in B lines. Here, can you see some B lines? Here, there are even more B lines, isn't it? The B lines are more, and they are much thicker as well. And as the fluid increases, you will see something like this, or it might be like this complete sheet of B line. And this means that the patient, if the patient is in heart failure, it's a pleural pulmonary edema, if you see something like this. And hopefully, as patient improves, you will see that there will be less and less. And that's how you will titrate the treatment. So there are lots of conditions which can be diagnosed with ultrasound. And as we are using more and more, we are finding that actually even more pathologies can be identified by lung ultrasound. These are the standard ones: pneumothorax, pleural effusion, pneumonia, and alveolar interstitial syndrome, which may be pulmonary edema, ARDS, or any cause of lung disease which is bilateral and uniformly affects the lung. The first one is the pneumothorax. Ultrasound is very, very sensitive to diagnose pneumothorax. Pneumothorax is actually called a diagnosis of exclusion in terms of lung ultrasound. You would see normal features in a normal patient. When patient has a pneumothorax, most of these signs will not be there. One of them is the pleural slide itself. As we said, pleural slide will happen only if the parietal and visceral pleural are close together. If there is pneumothorax, they are not close together, so you will not see pleural slide. There are other signs as well, which we'll go through, which absence of that will tell you that patient has got a pneumothorax. This here, do you think this patient has a pneumothorax? No, because you can see pleural slide, isn't it? And another thing is you can see B lines as well. Again, if you can see B lines, it means the patient doesn't have pneumothorax. Here, most likely patient has got a pneumothorax because we can't see the pleural slide. What you are seeing is because of the movement of the probe itself. The another most useful sign is called seashore sign, or a barcode sign. Here, what happens is you do a M mode. All of you know M mode, isn't it? You just put one ultrasound beam, and the fine movement of pleura and other structures in that line over a time is what you see in M mode. The lower part of this picture shows you if you put a beam across the lung, what you will get. Can you see there are two parts? This part looks different, which is the skin and subcutaneous, and this part looks different below the pleura. Okay, this looks like sea, and this looks like shore, yeah, like a sand. This is called seashore sign. If patient doesn't have pneumothorax, if the patient is normal, this is what you will see. Okay, so this is sea and this is shore, and the change happens at the level of the pleura. If the patient has got a pneumothorax, what happens is there is abolition of this seashore sign. So what you will see is called a barcode sign. See here, there is no sea and shore. It only looks like sea, isn't it? You can say either a barcode sign or a stratosphere sign. So loss of seashore sign or a presence of barcode sign is an indication that patient has got a pneumothorax. Here, just to explain, this is how the normal lung will look, and this is how the patient with pneumothorax will look. There is another very important point. This is a positive point actually. Most of the things in pneumothorax is negative. If it is not there, it will. But if there is a lung point is present, then you can 100% say that the patient has got a pneumothorax. It's a very pathognomonic of pneumothorax. So does anyone know what is lung point? Okay, tell me. Yes. Yes. That's correct. Yeah, very good. So basically, in a pneumothorax, there is a separation of pleura, parietal, and visceral pleura. But if the pneumothorax is small, after some point when there is no pneumothorax, the parietal and visceral pleura will come together. When a patient is breathing, you can actually see that movement of that junction where parietal and visceral pleura are coming together. And if it is a smaller pneumothorax, you'll be able to identify that point. In a M mode, this is how it will look. Can you see a differentiation here? On this side, you have a seashore sign. On this side, you have a barcode sign. This junction is called a lung point. This is on M mode. Actually, you can see it on normal 2B mode as well. Can you see here? It is coming up to here and then going back, coming up to here, here. Here there is a normal lung sliding. There is no lung sliding here. If you can see this, 100% you can say that the patient has got a pneumothorax. Now how the pneumothorax normally works is it will start in the most independent part of the lung, and as it gets bigger it will become bigger, so that because the lung will go collapse like this. So it is better to start from the most medial part, just lateral to the suprasternal junction, and then go laterally, and wherever you see the lung point that is the extent of the pneumothorax. Obviously if pneumothorax is very big, that lung point as you rightly said you will not see. Okay, so that is a very useful sign, because it is a non-independent entity, you sit the patient up or on 45 degrees or whatever your normal position is, and start at the most top and most medial part, because that's where you are more likely to find the pneumothorax. Pleural effusion, again ultrasound is I would say the best modality for diagnosis, as all of us will agree. For fluids, ultrasound is the best compared to chest x-ray, isn't it? So, and the benefit of ultrasound is even if a 20 ml of fluid is there, you'll be able to identify, whereas with chest x-ray you may not be able to identify at all. How do you identify pleural effusion? Usually a probe which goes deeper, like a 4C curvilinear probe is better. You start from the abdomen and you go up, passing the diaphragm, and you will see that there is a anechoic appearance in the posterior lateral recess of the thoracic cavity, because that's where the fluid will collect. This is how it will look like. It is not possible to miss, even for an unexperienced person. This black thing is the fluid. This is the diaphragm. This could be liver or spleen, depending on whether you are on the right side or left side. So it is very, very useful sign. The another sign which I don't find very useful, but in all the literature it is very consistently put, is if you put a M mode on the pleura above the lung, below the fluid, you will see that it will have a wavy appearance, because the fluid will make the pleura move like that. This is called sinusoid sign. It also means that whatever black thing you are seeing is fluid. Okay, the another very useful I feel diagnosis you can make with lung ultrasound is pneumonia. Okay, in pneumonia what you will see is a hypoechoic structure. The superficial boundary will correspond to the pleura itself. The deeper boundary will be a bit hazy and irregular, because that's the place where the pneumonia consolidation will be sort of mixing with the normal lung, and this is not a defined point. It will be a bit irregular. It is called a shed sign. This is what you will see in a normal lung. Okay, because there is no pathology, you can't see any lung. Okay, all you can see is that the diaphragm and the liver or spleen, and it keep missing, which is called a curtain sign. Okay, with this we will do in the hands-on workshop. In a pneumonia, what you will see that some hypoechoic structure above the diaphragm. Okay, which is now you can actually see the lung, because there is a pathology in the lung. You are able to see the lung. Before you were not able to see the lung at all. Another important sign is called dynamic air bronchogram. Okay, like in chest X-ray where you get a air bronchogram, which is a pathognomonic of pneumonia. In lung ultrasound, if you get a dynamic air bronchogram, that is pathognomonic of pneumonia as well. Can you see here the white punctiform lesions? Some signs, white dot, and with inspiration you see that they are becoming more bright. This basically means the air is going in and coming out with respiration. This will only happen in consolidation. It will not happen in atelectasis or lung collapse. And sometimes the atelectasis and consolidation will look exactly the same, and you may not be able to differentiate which is consolidation and which is atelectasis. But if you can see air bronchogram, you can say 100% that this is not collapse or not majorly collapse. It is definitely pneumonia, because in pneumonia the airways are still open, isn't it? All the pathology is outside the airway, whereas with collapse the airway is collapsed. So that's why there is not going to be any air going inside. So if you see dynamic air bronchogram like what you are seeing here, you can say that definitely this patient has got a pneumothorax. The other important findings we find is subpleural shedding, we call it. With a vascular probe, if you see that can you see some sort of abnormality just below the pleura? That is called subpleural shedding. This also is an indicator of pneumonia. This basically means this patient has got a very bad pneumonia. Usually when pneumonia happens, it will be very close to the airway itself, isn't it? Around there, the pathology will start. If it has gone up to the pleura, it means the whole lung is affected. So this patient has got a very bad pneumonia, or he has got ARDS, or so very pathology which has affected the most part of the lung. There are lots of studies actually to show whether lung ultrasound is useful. This is done by Dr. Daniel Lichtenstein himself. As you can see, sensitivity and specificity, it is very high. Okay, the sensitivity is high for pneumonia, embolism, pneumothorax, and all that. Specificity is consistently high for all the pathologies. And other studies show the same thing. This is just one example I've taken. There is an international evidence-based recommendation for point-of-care lung ultrasound. I think if you haven't read it before, you should read it. This was published in 2012. The idea was that they will publish it every 4 years, but unfortunately in 2016 nothing has come. I think they're still working on it. It hasn't. The next version has not been published yet. All the experts in lung ultrasound, they sat together. They went through all the literature available until 2012. They assessed and they came to a conclusion. So they used 320 references and they made 73 recommendations. And they graded their recommendation as A, B, C, D. And A was the strongest recommendation. Basically, it meant that further research is very unlikely to change our confidence in the estimate of effect or accuracy. And they gave strong level A recommendation for the following pathologies: alveolar interstitial syndrome, pneumothorax, pleural effusion, and pneumonia. It's not only for that. Actually, the more and more lung ultrasound we are using, more and more application we are finding. We can use lung ultrasound to look for reduced chest excursion in a collapse, for example, or a phrenic nerve palsy, for example. We can use it to assess weaning failure. We can assess diaphragmatic thickness, in a long-term ventilated patients where diaphragmatic atrophy has happened. You will be able to identify that. It can be used by the physiotherapist to assess the recruitment of lung. And more and more people are doing that actually, instead of going on the chest x-ray, which is like you can do only once in 2-3 days. This before and after every physiotherapy session you can do, and there are papers on that as well. And it can be obviously used for tracheostomy. This is how you would look for a diaphragmatic excursion. You use M mode. You use the curvilinear abdominal probe, and this is lever, or this is lever. It can be spleen as well, and this is the diaphragm. And you are looking at the vertical displacement. Normally it should be more than 1 centimeter. Here it's 2.67 centimeter. If it is less than 1 centimeter, it means the diaphragmatic excursion is less. This is diaphragmatic thickness. For this you need a vascular probe because it's a very superficial structure and you need a very high resolution. The diaphragm will look like this with a very thick margin on both sides. The normal thickness should be more than 1 millimeter. Okay, here it's 2.1 millimeter. And it will become bigger and thinner with inspiration and expiration, and the change in the thickness should be more than 10%. If it is less than 10%, it means there is problem with the diaphragmatic contraction, and that may be the reason why your patient is failing from weaning. It can be, as I said, can be used for recruitment. Here can you see some hypoechoic structure with this white punctiform signs. When the patient has more and more lung recruited, those signs will clear and you will see what is a curtain sign. So that's how we can use it. This is for tracheostomy. You can actually see where is the cricoid cartilage and where is the tracheal rings, and you can identify which tracheal ring, the space you want to go. It is very useful to look for blood vessels. Many of the people who don't, we use ultrasound to do in-time tracheostomy. So many people may not use it, but they will definitely use it for this, to look for blood vessels so that if they can avoid when they put the needle. Can you see 2 blood vessels there? What you are looking for is another 2 minutes. That's what you want to see is that is it in the midline? Is there anywhere it is not in the midline and you will be able to put your needle? You will see it in both the short axis and long axis. This is the long axis, so this is quite a big vessel actually, and if we had done a tracheostomy in this patient, we might have been in a bigger problem. Obviously we didn't do it. To summarize, lung ultrasound plays a valuable role in the assessment of critically ill patients. It can be used to diagnose many pathologies. These are some of the things which are mentioned: pneumonia, pneumothorax, pulmonary edema, pleural effusion, atelectasis. It is backed by a lot of evidence as we discussed, but it is very important to remember that use a lung ultrasound in the context of clinical picture. Don't just take the lung ultrasound finding and start treating patients. So clinical correlation is paramount. Okay, thank you.